I'm Prashant Yadav. I'm the Director of the Healthcare Research Initiative at the William Davidson Institute. Today we have with us Dr. Madhukar Pai. Madhukar Pai is an Associate Professor in the School of Public Health at McGill University. He's also the Associate Director of the Center for Tuberculosis at McGill and acts as a consultant to the Bill and Melinda Gates Foundation on the TB program and to many other philanthropic organizations who work on TB. Madhu, welcome to WDI, welcome to the University of Michigan.
Thank you, Prashant. Delighted to be here. Thank you for having me here.
So Madhu, I think a lot of people who work on global health or who work on markets for improving healthcare in the developing world tend to focus on medicines and vaccines, and you have a unique focus which is on diagnostics. So tell us more about why diagnostics are important for improving healthcare in the world, and what kinds of newer issues and nuances do diagnostic markets bring?
It's a great question, Prashant, one that I've been thinking about for a long time. And I completely agree with you that vaccines and drugs are the most dominant health technologies, presumably also because there's a bigger market attached to them from a developer's perspective. But I genuinely think that the first step in managing any disease is diagnosis. I mean, if I don't even know as a physician what I'm treating, my first obligation would be to make a correct diagnosis, and diagnostics aided decision making is the most precise way of practicing medicine. At the same time, having worked in countries like India, I realized that this is not an easy sell. When it's so cheap to just prescribe a series of broad spectrum antibiotics, half the time there is no motivation from anybody's part to actually go through the process of diagnosis. And also clinicians think that they are experts and they can see a case of malaria and TB and diagnose them instantaneously, that it's considered substandard clinical practice to actually ask for diagnosis. While in the Western world, diagnostics are so entrenched in our guidelines and protocols that everybody respects that, while empiric practice makes it so difficult to sell diagnostics. That's the reality, but I do think we should be pushing towards greater and greater use of good diagnostics. There again, it's a problem. There are so many bad diagnostics on the market in many poor countries that it's hard to separate the good and the bad. But I think a correct diagnosis with appropriate antibiotic therapy for infectious diseases would be less wasteful in terms of resources. And I would also argue that it will get patients better quickly than any other shotgun approach, which may or may not work. So I think there's both cost gains and better patient outcome gains that needs to come, but maybe it needs to be convincingly demonstrated. But it's almost so intuitive that good diagnosis will lead to better healthcare, that if it is not actually happening like that, maybe we need to make a case as to why good diagnostics should be the first step in disease management.
Yeah, so I think while it's easy to understand that for the health system as a whole and for the patient outcomes, good diagnosis is necessarily a better thing, it becomes unclear if the different actors in the health market, the prescriber, the retail pharmacy, or the lab, are all of the actors and their incentives even aligned to do diagnosis. I presume in many cases the market would prefer to just treat because drugs may be more expensive, or the volumes that can be gained by selling drugs without diagnosis may be larger than what you would get if you were to do proper diagnosis. So to what extent is incentive misalignment a problem, and how do you think about countering that?
I think incentive misalignment can go both ways. For example, we know in India that there's a mushrooming of these imaging centers, right? CT scan, MRI, whatnot. And many of them are flourishing because they give a good chunk of the money back to the ordering doctor. So here there is a misincentive, or there's an incentive to ask for an unnecessary CT scan or an MRI or whatever. And I don't think that's unique to India. It can happen in the US too. But I think that's a misincentive in the other direction. And I think there is a misincentive in the reverse direction, that it's much cheaper and easier and profitable to just give you an antibiotic and send you home and not ask you to do a diagnostic that you actually need, because you may then go to the next doctor who will do something that you want, a quick relief from symptoms, rapid shotgun treatment, and not go through the actual process of diagnosis. So I think it cuts both ways. And your work in malaria is a great example, where forever malaria was just managed with shotgun anti-malarial therapies, and the process of diagnosis was not really taken that seriously. And I think rapid tests have made people shift and actually not give anti-malarial drugs, because very often patients don't have malaria, right? So I think the negative result has value too, but I think that's not easy to convey, that much of the time the test will be negative, and it's a good thing that it's negative. Everybody thinks that it's a bad thing the test came out negative, and I think that's another problem on the value of a rule-out diagnosis. Okay, you don't have TB. It's not as bad as I thought, which is also a good thing to tell the patients.
Yeah. So I guess one of the questions that comes up, and I'm just struggling with this in other therapeutic areas, there are business and for-profit actors which run the health system, even in poor countries and even in low-income countries. Mm-hmm. And the business actors in the system care about profitability and care about what maximizes their revenue. Mm-hmm. So how do you balance it so that while doing more diagnosis and less treatment, if that is the optimal course for a patient, the business actors also maximize their revenue? How do you get the two parties to align?
I'm afraid that's not an easy thing to do. So from my experience in India, you take big hospitals in India, invariably they will not probably make most of their money by the doctor consultation. It's the ancillary tests and workup and other things that they make admitted patients do that actually brings the hospital a good chunk of the revenue. So that's why every hospital will have its own lab, and then doctors practicing there are actively encouraged to ask for more tests or ask for more investigation, and the more invasive or sophisticated the investigation, the bigger the margin that the hospital makes on it. So it is a rare enlightened hospital that will actually tell the physicians, you know what, only ask for what you need. There is really no reason to ask for 50 other tests just because somebody is admitted. But an average Indian patient, I think, is totally disempowered. They have no idea half the time what they're being asked to do. And in the end, when they get a big bill at the time of discharge, they have no idea where that bill came from, and there's no transparency in pricing at all. It's a scary market to get into. I mean, I wouldn't want to be a patient who's just been admitted at a big hospital, and I have no idea how big a bill I'm going to get hit with when I'm ready to get discharged in a week's time. It's very scary, Prashant. An average patient there is struggling to know what's really happening to them, which of these is necessary, which of this, and why is the test really that expensive? What's the markup? Nobody knows.
So you do a lot of work on TB diagnostics more specifically. So tell us a little bit more about the field of tuberculosis and the role of diagnostics in TB. And you mentioned earlier good quality and bad quality. So what is good quality, what is bad, and how is it hurting both the public health outcomes, but how is it also hurting the market and the profitability? And how big is TB diagnostics market in the world, and are we just thinking of it too small?
Right. So TB is one disease where we absolutely want a good confirmatory diagnosis. Otherwise, 6 months of pretty toxic treatment has to be taken. Unlike malaria, for example, where I think the toxicity or a respiratory tract infection where you gave 3 days of some broad spectrum antibiotic, the amount of damage is probably not significant. TB is one where we have to get a microbiological diagnosis. So for the national TB programs, which is the public sector programs, for a century or so, there's just been one test, a smear microscopy test, where you take the sputum, you smear it, you read it under a slide, and then that tells you whether there's TB bugs in the slide or not. Unfortunately, that technology is not only antiquated, but genuinely insensitive. The human eye cannot pick up the bacteria unless they are in big amounts. So a good amount of TB will get missed by that technology. But that's all that exists today. If you go to an African national TB program, in all likelihood, they have that 100-year-old technology. The biggest advance there is the tests like GeneXpert, which have, for the first time, opened the doors for rapid molecular diagnosis, which is far more sensitive than sputum smears because the DNA is amplified many thousand-fold and can get results, can also diagnose drug resistance at the same time, which sputum smears can never do. And I think thanks to donors and agencies like Gates and Unitaid, this technology is finally reaching a stage of rollout. More than 3 million cartridges have been used since that test came on board and got strong WHO endorsement. But all this is new. That's why there's a lot of excitement about TB diagnostics in the TB community, because for a century, all we had was a pretty low-tech sputum smear test. The market size was estimated to be about $1 billion. $1 billion spent on various TB tests per year globally, but that's 10 years old. That analysis by FIND and WHO is now considered dated because it predates GeneXpert and all of the wave of WHO endorsed technologies that we have today. So we are currently being asked to kind of do a small scale update of that global analysis, and we're already finding that the market is pretty substantial. Take South Africa, for example. Of the 3 million GeneXpert tests done till date, more than 60% has been purchased by just one country, South Africa. So countries are beginning to invest in better technologies now. So my prediction would be the market size, if done today, would show a market much more than $1 billion, because none of these existed in the past. Private sector is a whole another story. Now, the sputum smear, GeneXpert, they're all happening through national TB programs. But private sectors in countries like India have been doing their own version of TB medicine practice that nobody has ever understood. For example, until recently, Indian private sector was using antibody TB tests, which not a single guideline anywhere in the world has ever recommended. And just because they're popular doesn't mean they're accurate. They are inaccurate, and finally WHO came out with a clear policy saying that they're inaccurate. Now the question for people like me is, how do we make WHO approved tests much more affordable so that they can take over these inaccurate blood tests that were popular in the country? And here we run into some serious market issues, because WHO approved tests were never offered at subsidized prices to the private sector. Private sector was considered the rich market and therefore open to market pricing, and all of this buy down and negotiated pricing never applied to the private sector. I think that's one place where I think there's tremendous scope for the business community to step in and try and re-normalize the market, make good tests more affordable, and somehow get them to take over the space left by bad technologies being crowded out. And I think groups like CHAI and others and Unitaid are actively interested in this particular space.
So tell us a little bit more about your work on improving the quality of TB diagnosis in India. We've heard about iPAQ, the project that you're working on jointly with other organizations. So tell us more about how is the project designed, and how does it ensure that affordability of higher quality TB diagnostics is maintained for the patient while keeping incentives for different actors in the system?
Correct. So this is a predominantly private sector initiative, because these inaccurate antibody tests were being used in the private sector. And after the government of India banned them, there was a need for good WHO approved tests to be affordable to take that space. And we realized that WHO approved tests were invariably very expensive in the Indian private market for a variety of reasons. Like I said, companies and agencies never considered private sector as part of the negotiated pricing agreement. Special pricing was only for public sector, so private sector was left out. And private sector prices will invariably be several-fold higher than the public sector price. And on top of that, the private sector inflates the overall price to a factor of 3 to 4-fold. which means they have their margins, the provider margins, the distributor margins, everybody margins, plus import duties, which the government of India levies on foreign diagnostics. All of this meant that a test like GeneXpert would be sold for $50, $60, $70 in the private market. Essentially, that it was a tiny fraction of the Indian public that could in fact afford such tests. So I think the iPAQ coalition, which Chai and other groups and non-profits all came together and facilitated this year, was essentially a way of consolidating laboratories and convincing the WHO approved manufacturers like Cepheid and bioMérieux, BD and Hein, that they should see India as a mass market model, where the model is of high volumes but low margins. And in order to make it affordable, and most patients with TB in India are poor, cannot afford this premium pricing, and that it would be in their interest as well as the India's interest that they drop the price to almost the same level as the public. But in turn, the labs that join iPAQ will have to agree not to exceed a certain ceiling price. And that ceiling price does give them some margins, but it's nowhere as high as a 3 to 4 times higher margin that they were charging in the past. And so everybody's margins have been dropped. And they all agreed to do that, which is quite amazing that they have done this as a service for TB, and they understand that TB is a disease of poverty. And so with this approach, the idea being if these WHO approved tests are now about 50% lower than the market price, the volumes will go up. And eventually the higher volumes will kind of compensate for the lower margins that all of the various stakeholders are accepting. So that's effectively the switch from the premium pricing of a $70 test to something in the range of $30, which many more Indians can afford and are much better quality than the banned tests. In addition, the labs that are involved, I'm happy now there are 50 labs across India, including some of the largest network chain labs, have all agreed to join iPAQ. And the amount of volumes is significantly higher than earlier when it was premium priced. So we are beginning to see a larger number of products being used, but they all have to have accreditation. They all have to have external quality assurance. I have to agree to participate in that because quality also is important. And they all have to agree to report all cases to the Indian TB program because that is now mandatory. The Indian government wants every TB case to be notified to the Indian government. So this is our way of public-private partnership, that all private labs start notifying cases of TB and MDR TB to the public sector so that the government of India knows exactly what's happening. And therefore, we can link patients to the right treatment. Treatment is still free in the public sector. So even if the diagnosis is made in the private sector, these patients can be referred to the National TB Control Program for free treatment, both drug-resistant as well as drug-sensitive TB. So it's an exciting initiative, but the fact of the matter is everybody's margins are now less for the good tests. So there is still a temptation to promote or use tests that offer more margins, even if they're not as good as a WHO-approved test. Those are the sorts of market forces that one is still trying to figure out.
So even though the per unit margins have dropped for the labs and other intermediaries in the system,
yes.
And the per unit margins probably have also come down for the manufacturers, given that they have negotiated a special price.
Yes.
But the volume expansion that is happening is perhaps at least making them offset whatever they're losing in terms of per unit margins, or if it goes well, then perhaps even increasing it more.
Correct. So we had about a year and a half ago computed the Indian diagnostics market to be worth about $220 million. That's a total expenditure, of which private sector had a higher share than the public sector, because the public sector was mostly using sputum smears, which are very inexpensive. So that was the premise that we told the companies that, look, there is a big market underneath it all, but we need to reach a certain volume. And I think this high volume, low margin model, it's kind of a chicken and egg situation, right? Everybody wants volumes right away. nobody has the patience to wait for the volumes to build up, right? So with great effort, Chai and others have brought this up to 50 labs. But to go to 100, to go to 1,000 labs is when I think the true potential of the Indian volumes will finally manifest itself. But to get to that point, A, we need time, B, we need some serious demand generation work. How do we spread the word that 5 WHO approved tests are now available at much less than it is outside in these 50 labs? So some demand generation can be done by the labs themselves. It is their job to go out and tell their clientele. We could do mass advertising. We could do all sorts of CMEs and symposia. But the fact of the matter is 5 WHO approved tests, good quality tests with strong evidence backing them, are now much more affordable than they were 6 months ago in the same Indian private sector. But people need to know this. And then people need to ask for it. Physicians need to demand these tests over other suboptimal tests. Only then the volumes will start ratcheting up. That's when everybody will begin to realize that this model even works. So if everybody wants volumes right away, then it just cannot happen. So I don't know how you've dealt with this problem in your other work, that this volume will come provided you're willing to give it the time and put in the energies to promote this model. It will not just going to happen overnight. And if one is there in the short haul, I don't think this is a very desirable situation. One needs to be in it for the longer haul to begin to see benefits of this model.
Absolutely. So I think, but if it works, which means if the volume expansion does happen and there is enough patience amongst the stakeholders to wait for that duration, then we have a model in which patients are getting higher quality TB tests at a cheaper price. All of the stakeholders in the system, including the manufacturers, are actually making more revenue than they are currently.
Yes.
So it's a clear example of a win-win where all parties stand to gain from doing this. It's just a matter of short-term versus long-term, or not having the right approaches to show how this can be achieved. And it seems like iPAQ is helping to make that happen, at least for one specific area.
At least, to even reach this level of 50 labs, 5 tests at such more affordable prices, to me is a mini miracle by itself. Because my expectations were not that high, because I know how tough the Indian private market is to even promote the WHO approved tests over others. But now, interestingly enough, and this is an issue to consider, would this model be likely to be more beneficial if other diagnostics were added beyond TB? This is a question of how specialized do you want to be versus make it. So for example, there are people who come and ask me, HPV molecular testing is so expensive in India. Could iPAQ consider that, right? What about HIV viral load? Why not think of anything for where the pricing is disproportionate to the disease of poverty? The tests are good but unaffordable. Can we consider this similar pricing? I can see why it could be attractive to companies, because companies are reluctant to drop their prices if at the end patients are still going to pay a very big amount of money, because then they know they've essentially given their margins to the other people on the ground. So here they have a satisfaction that their price reduction is actually translating into tangible benefits for the patient price. To that extent, I can see that this is attractive for them. But we need to figure out how physicians figure in this model, because in India, it's the physicians who decide which test, where, how, and they are the ones who are empowered to make decisions. And we need to convince physicians that there are a lot of good diagnostics that are more affordable, and by using them, their practice will benefit. I think that is another area of discussion. If they genuinely believe that they don't need a diagnostic test, then I think we are sunk, because there is no easy way of getting around that problem. And I think that's where, how do you get physicians to follow guidelines becomes critical, because if they did follow guidelines, and it's pretty clear that diagnostics are a critical step of any guideline, And I think that is where, in an unregulated market like India, physician behaviors, I think, are the toughest to change.
Madhu, this is fantastic, and given that you are a medical doctor by training, but are still working with markets and using market-based approaches to improve public health, it is fantastic to hear that, and good luck with iPAQ. I hope it scales up and becomes much bigger. We all look forward to that. And thank you once again for coming to the William Davidson Institute and the University of Michigan.
Thank you, Prashant. It's been a real pleasure.